Okay. Good afternoon again. Thank you all for joining. I think Dr. Sundaram is there. Yeah, Sundaram can present
Yes,
this
sir.
case.
Yes, sir. Yes, sir.
Yeah, Sundaram, please.
Sir, yes, sir. Sir, able to hear me, sir?
Yeah, I can hear you. I can.
Sir, able to hear me?
Yes,
Sir.
yes, yes.
Sir, this patient is a 22-year-old female diagnosed as
Okay.
bot spine D7, D8 level with paraspinal
Okay.
collection. She had back pain for 2 months, but she presented to hospital only after she was not able to move her lower limbs. She had difficulty in moving lower limbs, so she came here. And after the diagnosis, spot spine with paraspinal collection, she was started on ATT. She was kept on ATT for 2 weeks. After that, also the power did not improve in the lower limb, so orthopedician wanted to take up the case. And when she was asked for anesthesia fitness, when we saw the patient, she is conscious oriented, but temperature of 101 Fahrenheit was there, tachycardia 140 was there, and height of 140 centimeters, BMI around 19, sir. So since after 2 weeks of ATT, patient did not have any symptoms, we took up the case and we went with general anesthesia with controlled ventilation. As soon as we initiated ventilation, though the preoperative saturation was around 95 to 96% in room air, she was a bit febrile, tachycardic, tachypneic, so breath was not of adequate depth, but it was enough to maintain saturation. After we initiated anesthesia and we started positive pressure ventilation, we found that the FiO2 was little bit increasing. In room air, she was
Sorry to
maintaining around
interpret.
SpO2 of 95.
Sorry to intervene, Dr. Sundaram.
Yes, sir.
Can you be on video so that it will be more interactive rather than video being paused? It will.
Oh, sorry, sir. I did not notice. I was concentrating on audio. Sorry, sir.
Yeah.
So
Okay.
general anesthesia with controlled ventilation was provided. Ventilatory parameters required escalation of FiO2 from 50% to 80% to maintain SpO2. And hemodynamics, usually after anesthesia, we will have some, allow some 20% of base fall from baseline of heart rate and BP. And this patient also had that fall, but we were unable to maintain MAP above 65 mmHg. So we started her on noradrenaline, sir. And this one I have given there. We have prepared a infusion noradrenaline in 50 ml NS 4 milligram, and we kept it 4 ml per hour to maintain the BP between 160 to 120/80. And but the intraoperatively tachycardia was persistent between 140 to 152 per minute. Surgery, we know that the patient is little bit a sick patient, so we had a senior orthopedician who did the case. Like, he wanted to relieve the collection as well as do some debridement and give some stabilization to that part of thoracic spine. Surgery lasted for 2 hours with blood loss of 250 ml. 1 unit Paxil transfusion was done. The hemoglobin was 9. Blood loss 250 ml was compensated with the blood PRBC transfusion because we had the challenge of also in able to maintain. So we so in main more than please. Please. Sir, can you hear me, sir?
Yeah, I think there is some internet connectivity problem. Yeah, we are hearing. We are able to hear you now, Sundaram. Please.
Yes, sir. Yes, sir. So I know the history, sir. Just go ahead. And this is on 0 post-operative day. After 2 hours of surgery, we don't want to extubate the patient because even ABG was pH was somewhere around 7.2. Even for an usual normal patient, because of hypothermia and tissue in general, we used to have a little bit of acidosis in the ABG. But usually after recovery, they used to come up to 7.3 or 7.4. But this patient being a patient immediately on the next day, on the first post-operative day, we were able to balance all temperature and acidosis and all, and 7.3 pH we got. And fortunately, the FiO2 requirement also classically came down. So we were able to bring down FiO2 at least till 50 to maintain SpO2 more than 95 or something on first post-operative day. So so from controlled ventilation, we also switched over to CPAP PSV mode as how we do for a patient with a normal lung. And noradrenaline requirement also came down. And usually during perioperative period, we will have a surge of blood glucose usually for most of the patients who are in stress. But for this patient, whenever we measure CBG, it was somewhere around 80 only. So this is a somewhat peculiar thing which we noticed in this patient. And hemodynamic parameters were okay, and ABG somewhere around PA 7.3, but still some metabolic acidosis component was there. So we actually extubated the patient in our recovery anesthesia unit on first post-operative day, because further we do not know, the collection has been drained, analgesia part covered, lungs are also recovered. So we went ahead with the extubation of the patient. And we pretty well know that in spite of all this, her preoperative condition, like the paraplegia is still there, and further AED is also to be provided. We thought a medical care unit will be a better place to take care of drug administration as well as monitoring of all the organs and other post-operative care for this patient. And so we shifted to MIC for further management. As she was weaned from the ventilator, she was with some nasal face mask. The only thing on second post-operative day, bilirubin, which was around 2 milligram per deciliter, went up till 10 milligram per deciliter. So this patient bilirubin increase, since she was on ATT for the past 2 weeks, we thought it should be because of ATT induced. But still, this we did not expect that much surge of bilirubin increase, because she was for the past 2 weeks she was on ATT. Why immediately after surgery this should happen, we don't know. And tachycardia, tachypnea did not come to baseline. Something is going wrong with the patient, but still we weaned her and we were kept her in ICU observation. And that second post-operative night, that resident told that patient had sudden episode of bradycardia when heart rate went down till up to 40, and she has to be taken up in ACLS protocol. So as soon as ACLS protocol was initiated, ROSC they were able to obtain. But as whenever we initiate a controlled ventilation from a spontaneous ventilation, patient had desaturation episodes and increasing FiO2 to maintain SpO2, same thing. But unlike our intraoperative day, this episode was not that easy for us to come down on FiO2. Here the FiO2 kept on increasing. On the second post-operative day, we were able to manage with that ARDS low tidal volume, all that strategy, like around 350 to 360 ml and increasing respiratory rate. But on third post-operative day, other organs also started to become like, we were very clear that some acute liver dysfunction is happening to the patient because of bilirubin increase and all that. And urea creatinine also started to increase. And if when these two organs are in stress, obviously we noticed tachypnea, tachycardia. Now we are in a mode that whether we have to take her deeply paralyzed and then ventilate or not. So we went ahead with paralyzing the patient and ventilating her, but we were not able to achieve a very good tidal volume, exhale tidal volume for this patient. So airway pressure started to increase, exhale tidal volume started to decrease, and we do not, and this problem is going to be a big problem lasting for because liver injury. She was already on ATT for the past 2 weeks. So how to go ahead? We had a big challenge in managing ventilator for this patient, and other challenges are increasing organ dysfunction for this patient, sir. So our concern was actually, and another 2 days we lost the patient, unfortunately. That liver function did not come back to normal. And in this setting, we did not expect the lung to become so bad and the vasopressor to increasing vasopressor requirement. And the main problem is the tachypnea, tachycardia. When this much of problem is happening to the patient, there is naturally a compensatory mechanism in the body to give tachypnea and tachycardia. Now, how long we can, if we are going to paralyze the patient, we are not able to achieve that much of ventilation. Comparatively, in a CPAP PS mode, we are getting a good amount of exhale tidal volume and good ABG, but patient is getting tired. So when the patient is getting tired, obviously the heart rate is increasing. We do not know, already liver is in threat, lung is in threat, the heart might go threat at any point of time. So this tricky way, in the same day, whether we can keep the patient fully on control mode or intermittently we can paralyze, how to focus in this particular case, whether control mode will be better or CPAP mode will be better, which will give less stress to the heart. So if less stress to the heart, control mode we are going. How are we meet up the compensatory compensatory mechanism which the body would naturally provide with tachypnea, tachycardia in a mechanical ventilatory setting? These are my questions, sir.
Okay. Thank you, Sundaram. You're from Chennai, Sundaram Doganathan?
Yes, sir. Yes, sir.
Okay. Good. You had challenges in while managing the patient. We'll discuss this. Good to have you come up with the case actually. So we understood this case. Okay, briefly, you wanted to take this case with a tubercular abscess, paravent abscess. During intro, long-standing problem is there. Intro, there was a problem. So hypotension, desaturation. Second day, you had some difficulties. You had thought of working. There is a problem with the liver and kidney injury, and although selected problem was there, you try to manage. But first post-op, you try to even you extubated that patient on first day itself, even though there is acidosis is there, and such you thought oxygen improving, Norden is better dose. You thought it was improving, but there was acidosis, tachycardia was there. You extubated, shifted to ICU there, but ICU patient had one bad event. Okay, you were achieved ROAC, then there was a difficulty in ventilation. So okay, these are the challenges you want to know. So first of all, I will start the discussion. Dr. Mahadev will be there. I expected some more doctors from last time. They are asking so many questions about the ventilator. They are not there. I think they have to go through this this discussion because most of the question, whatever they asked last time, we can able to answer here. So first question is, which mode? It is the always this is the problem. Every doctor have beginners. We want to know which mode is the best mode to treat, maybe ARDS, to be healthy lungs, with maybe COPD or asthma patient. That is always will be there. That is the one big questions will be there. I will end this actually. Come up with the this one mode I'm talking. Okay. I thought sepsis with mechanical ventilation. This is the what we want to discuss. See, mode, when come to the mode, what I'm telling is, either you can consider a volume control mode or pressure control mode or SIME mode. Any mode you can select according to your comfort. According to your comfort zone, mode should be selected. Okay. So just it's like a reaching from Chennai to Bangalore, you want to reach. You can reach Chennai to Bangalore by car or by aeroplane. Okay. So it is the how we want to travel, that's matter. So the settings what we put in the patient with the respect ventilator, those are important. Those are very important. So actually, when we ask for this, nobody came up with the case. So we just took this case, similar case.
Dr. Raghu, I wanted to give one more example for simplicity of understanding. It is like driving a car, whether you're driving electric car, manual, automatic, it doesn't matter. The rules of the traffic rules has to be respected. And that ensures that you will be safely reaching your destination, rather than which car you drive doesn't matter. It's similar to that. Yeah, please continue.
Yeah. Before this is a similar case. I'm go through your case only. This is a similar case taken for surgery. See, any patient, if you want to take up for ventilation, first you have to know about the patient. Okay, what is the pathophysiology? Okay, that is more important. These are things important before initiation. especially in sepsis. Sepsis very much matters here. So here, even though patient is intra, patient is requiring ventilations, but look at this same similar patient here. This is the patient came with the abdominal pain, hypertension, diabetes. There is a distress is there. So when you know that before intubation, there is some distress is there, means there is real problem is there. Patient have loss of appetite, fatigue and all. Look at the heart rate 120. That patient also heart rate was 120. BP was low. So here in your search case, already intra there was a intubated patient, BP was low. Usually in ICU, what will happen? Usually patient come to the emergency, BP below, tachycardia will be there, some sepsis source will be there. Here also sepsis source, because last time many people are discussing about the how to manage sepsis and then how to take to intubation ventilation, that part. I will discuss that preliminary part, then come to your case also. So you look at this rate, heart respiratory rate is 30. That's a very important point patient is telling here. Patient want high respiratory rate to maintain his metabolic status. That is the most important thing. That will not understand. Here, look at this case, another point, saturation is 99, but requiring oxygen, 5 liters of oxygen, and acidotic breathing. So most of the patient in your emergency or ICU in OT before in sepsis patient, if you want it, there will be a tachypnea will be there, patient will be acidotic breathing or tachypnea or response breathing requiring oxygen. Okay, if you do ABG, lactate will be high. So what my point here is, what is the basic basal condition before you are attempt to intubate? That's where the ventilation starts. That's a very important point I want to highlight. If you look at this ABG, you would have mentioned more about ABG here, only you are mentioned about the bicarb. But I want to tell more about the moment you talk, the emergency patient comes to the ICU, you immediately within 1 minute or 2 minutes you can be able to take ABG. Look at the ABG here. ABG tell most of the things. Here ABG 7.23, PCO2 34, PaO2 110, bicarb 14. So my thing to put this ABG here is, anyway you have to manage ABC. Before ABC, just look at the ABG. So here anybody can read, here pH is acidosis, bicarb is less than 24, so it's a metabolic acidosis. If you apply Winter's formula, that is 1.5 times the bicarbonate, that is 14 plus 8, it becomes 29 plus or minus 2, that is 27 to 31. So my point here is PCO2 should be 27 or max 31. Means already PCO2 is high, means that he is not hyperventilating. That is the depending upon the metabolic need. Actually, he should still more hyperventilate to wash out carbon dioxide to bring PCO2. Means he is already tiring. This one word, tiring, means very important. Even though case study itself telling, history giving, he is very much tired. That fatigueness, everything is there. But look at, there is already some CO2 retention is there. Actually, you should hyperventilate more. That's what the the important. If you one step, if you go ahead further, imagine most of the patient in the ABG. I want to put this point here for all the students. Look, try to check the anion gap. Anion gap is sodium is 130, chloride is 100. What is anion gap? Sodium minus chloride plus bicarbonate. Chloride plus bicarbonate. Bicarbonate is 14 here. 114. 130 minus 114 is 16. Whenever the high anion gap metabolic acidosis, this is called high anion gap metabolic acidosis is there, look at the causes. It may be lactate. Look at the lactate. If lactate is high, there is a hypoperfusion. Always think hypoperfusion is the cause for acidosis. Try to treat it. Why I'm telling this point here is if you're not concentrating the hypoperfusion and lactate or sepsis control, your ventilation, how much you want to do, that will not be helpful. So the problem here, what is the problem that you have to correct meanwhile your ventilation, while ventilating these patients? Imagine if there is a RFTs, imagine this case is normal. If it is high, it may be renal acidosis, uric acidosis. In that case, rather ventilation is required, but correcting the cause is dialysis. So what I'm telling is, correcting the cause is very important while ventilating this patient. This you have to think before once you get one ABG, I'm telling. It may be DKA. Always, most of the sepsis patient will have a DKA. Look at the urine ketones. If you know the urine ketones negative, glucose is high, think of DKA. There is a possibility, high possibility of DKA. Lactate is normal. Acidosis is there. that decay will be there. By giving lot of fluids, insulin, you can correct the acidosis problem. Not only ventilation. Ventilation is important. I'm going to tell how to ventilate this patient, but these are the patient. If nothing is there, and you are just coming patient, yesterday patient came with the, one drug, anaphylaxis, did not reveal the poisoning, that is aluminum phosphate poisoning. At Picor was 8. I was insisting something wrong. You tell me what you are taken. Before bradycardia intubation is telling I have taken the aluminum phosphate tablet. That is the cereal tablet they will keep for the, grain tablet they will keep for the grains. That will cause severe metabolic acidosis. That patient, meanwhile, patient arrested. Imagine if he not utter the word of tablet there, poisoning there, because his lactate was normal, RFT was normal, ketone was negative, only acidosis was there. You just came to ICU, 1 hour he was able to intubate. Next day, within night he arrested. So these are the important points I'm telling. Identify the cause within few minutes only while managing the patients. Here, airway. While intubating this patient, very important. While intubating this patient is septic shock patient. Very important point I want to tell you. Most of the patient will have bradycardia arrest while intubation only. Why it happens? Why it happens? It happens because, as I mentioned, these patients required. Please try to mute if other people actually. Okay. Okay. Why it is important is, as I told here, patient having higher rate, respiratory 30, means hyperventilation is the key. He's managing pH. He's washing, because of acidosis there, he's washing out the carbon dioxide and try to maintain pH normal. The moment you give sedation, like if you're given here, the shock is there, you are given you are given ketamine in this patient, or if you think hemodynamic stability, if you want, you are given etomidate also. Some drug you are used here, etomidate or ketamine, while intubation. Even etomidate also not advisable in sepsis patient. Better to use ketamine when there is a shock is there. You would have been used ketamine because shock is there. You're intubating. While intubating, if you're not ventilating appropriately, if you manage ventilation 10 breaths per minute, hyperventilation, what happens? PCO build up and patient may arrest. Or if you put back on ventilator with a lower respiratory rate, imagine the respiratory is 30. If you are using rate of maintaining rate of 10 to 12 normal respiratory, if you keep that patient hyperventilate further, pH drops and you may arrest. I'm telling what is important in sepsis here is these patients while intubation also make sure that you want hyperventilate before while intubation and even after ventilation. Hyperventilation, how much hyperventilate? Imagine usually sepsis patient, usually we need 5 to 6 liters minute ventilation. These people needs 100 to 200% more than that. Means you may require 20 to 12 liters of minute ventilation. That is the important thing you have to maintain during intubation, even during ventilation also. Hyperventilation is the things. And drugs, as you are anesthetist, you are able to manage, but make sure that also causes vasodilatation. Hydration is the key. Give a lot of fluids to maintain BP before intubation and even while after intubation. Look at the IVC. If IVC is low, give fluids and try to maintain the BP. So here the point here is here hyperventilation. That is many people will forget while ventilating these patients. Here while ventilation, that's what the thing here. I told here saturation is 99 with 5 liters. Why you should require 5 liters of oxygen? You have to think the patient, any patient requiring some amount of oxygen means there is some VQ mismatch is there. To correct the VQ mismatch, not only ventilation, some amount of PEEP is also required there. So that is very important. If you're requiring 5 liters or 10 liters means there is a need of PEEP. That also you have to think. Here, minute ventilation, usually 10 to 12 liters minutes, even more sometimes in acidotic breathing, keep higher respiratory rate. How to select the respiratory rate? Imagine it is a 12 liters means 12,000 ml divided by, imagine usually we took the tidal volume of 8 ml per kg. 12,000 by 8 ml means is 60 kg, 480 ml. So it is a 25 respiratory rate. This is how you should calculate. You should know the hyperventilation, how much minute ventilation need, divided by the tidal volume, what you expect. How much tidal volume you expect? 8 ml per kg. That is very important. And mode is very important. I'm going to talk on this mode actually. What is the mode required? Okay, Sundaram, this is the your basic question actually. Which mode is required in ARDS? That is the one thing I want to tell. Okay, I will tell you how to select the mode. Okay, if you imagine, basically we have three modes everybody want to select: volume control, pressure control, SI mode. Some people will do PRBC mode also. Okay, so these are the three modes you want to select. As Dr. Mahadev rightly told, it is the how you want to deliver the tidal volume, how you want to deliver the flow. Okay, and looking at the traffic signals means looking at the avoiding the lung injury, Basically, we want to manage protective lung ventilation is the key here in sepsis. Usually these patients go for ARDS. So when you know that these patients going for ARDS, why not we go for protective lung ventilations? So protective lung ventilation is required even for healthy lungs also. It's not only for the ARDS patient, even in post-operation also is required. So why it is this protective lung ventilations? Especially ARDS, it can happen even in the post-op patient, and this patient, I'm telling, this patient almost 2 months bedridden. So 2 months bedridden, unable to walk, there will be some amount of basal atelectasis, some amount of EQ mismatch already there. So what if you take the CT in this patient, what happens? There will be dependent collapse will be there. That is very important. It is not homogeneous. It's completely non-homogeneous. And we can see there is some amount of edema will be there in the ARDS patient, and small lung volume is there, where we have to ventilate. So this preserve normal lungs where we have to ventilate, because in ARDS especially. In healthy lungs also, we don't want to harm the lungs. What is meant by harming the lungs? That is the important here. So challenge here in any patient in sepsis ARDS, healthy lung post-op patients, any patient, we should not harm the lungs. That is the most important parameter. So here we should know lung protective ventilation strategies. And Sundaram was talking about, I don't want to strain the heart protective lung ventilations, and also diaphragm protective lung ventilation. These are the different strategies we can adopt while ventilating this patient. Sundaram, if any doubt is there, you can ask me. Okay. So what are the traumas we develop here? We develop trauma while ventilation is, one is atelectative trauma. Atelectative trauma means because of the alveoli opening and closing, there will be shear stress will be developed in the alveolar wall, shear stress. That causes damage to the alveolar wall. That is called atelectasis induced trauma, atelectative trauma. So this is a one important trauma. So in your patient also, have you able to manage this atelectative trauma while initiation of ventilator itself? That is the one thing you want to ask yourself. Another one is, another ventilation is volume trauma. Volume trauma means if you usually we use 8 ml per kg. Earlier, 20 years back, 10 to 12 ml per kg was there. Now it is a standard of care. We have to reduce the tidal volume to 8 ml per kg. 8 ml per kg is the for normal lungs. For the ARDS, 6 ml per kg. So if you use higher tidal volume, imagine 8 ml per kg in ARDS patient itself is a more, or 10 ml per kg in healthy lungs itself is a more for the lungs. That can cause volume induced trauma, that is volume trauma. Have you used the adequate volume? That you have to think. This patient, especially your TB patient while ventilation. Another one is atelectative trauma I discussed. Another one is barotrauma. Barotrauma means pressure induced trauma. If the more pressure, the alveoli distance more and more and rupture one time. That can cause pneumothorax, can cause, pneumomediastinum. So we have to avoid these traumas. One is volume trauma because of high tidal volume, because of increased pressure by barotrauma, because of opening and closing of the alveoli, atelectative trauma. Another one is biotrauma we call, because of mechanotransduction, means ventilator, in spite of the lung, you are using all this, avoiding all this trauma, because of the shear stress developing the alveolar wall can release interleukin 1 and tumor factor that can spread to the other lung or other part of the blood. It can cause even multi-organ failure also. So in your patient, you are clearly mentioned this patient may go for multi-organ failure. Not only sepsis causing multi-organ failure, because of a ventilator-induced lung injury also can cause this one. What is ventilator-induced lung injury can cause multi-organ failure. This is a very important graph. This is the PV loop, pressure volume loop. So what is happening here? You have to concentrate here. Okay. This is the okay. Here I mentioned here, patient here, this is a, imagine this is the zero pressure. This is the pressure of 5. Okay. Okay. So what is happening? This is 10. Here, even though pressure increased from 0 to 10, what is happening? There is no increase in the volume that I mentioned in the last class. So you need some amount of pressure to keep the alveoli open. That is the lower inflection point. What is lower inflection point? Change in the slope. Here slope is supposed to be like this, but there is a sudden change in the slope. Change in the slope of the line in the, you can say, ascending limb of the PV loop. That is called lower inflection point. If lower inflection point here is here at the level of the 10, means he needs 10 centimeter of water of PEEP to keep the alveoli open, to avoid atelectotrauma. These are the things you should know, strategy to protective ventilations. Okay. Here, if you see, as the pressure increasing here, sorry, it is gone. As the pressure is increasing here, okay, even though volume is increased significantly, at one point here, even though pressure is increasing here, but there is no much change in the volume. Volume is fixed here. No. Sorry. Okay. Even though even though pressure is increased here, volume is not much increasing here. So this is called okay. This is volume is not increased here. This is called, what you call it is upper inflection point. There's another slope here. Actually, slope is supposed to start continue here, but is not continuing. There is a change in the slope. This is upper inflection point. So idea here is we have to keep the P at the lower inflection point, and we should not increase the pressure above this upper inflection point. This is called protective lung ventilation. This is the very important strategy you should know. You should keep the P at the level of the lower inflection point, and it did not increase the pressure above the upper inflection point. Usually we keep plateau pressure, we keep plateau pressure like a less than 30. Always remember plateau pressure should be less than 30 in ARDS patient. In this patient, how you should think again, whether you are maintain the plateau pressure less than 30 to avoid barotrauma, and have you keep the P at the level of the lower inflection point to avoid atelectotrauma. Sometimes you are not able, many times you are not able to see lower inflection point. That time we'll see what can be done. So what I'm telling here is you have to make sure that you are ventilating in the protective lung ventilation. This is called, I think Dr. Mahadev want to tell to avoid, to check the traffic signals, whether the pressure is increasing or not, whether volume is more or not. You have to see these things. So this is the protective ventilations. So protective lung ventilation. Here, which mode is important? That is the one thing everybody want to know, the mode actually. I will take mode actually here in this class. Here we will take mode. See what is happening here. Mode. So if you imagine, if you use the volume control mode, so what you are doing in volume control mode, as I mentioned, you are fixing the tidal volume. Okay, you are fixing the flow. You are fixing two variables. How many variables are there? Volume, pressure, flow, and time. So here, volume control mode, you are controlling this. So what varies here? Pressure varies. Okay, time also varies. So basically, when you put a volume control mode, this is ACME volume control mode, assist control volume control mode. There you are fixing the tidal volume. So pressure is fixing tidal volume and flow. Pressure is varying. So how will be the graph will be there if you see pressure here in the pressure? How it graph will be there? I showed here. In the here tidal volume is fixed. Pressure increases gradually. I told sharp in appearance, then stop and drops to the during expiration. This is how the graph will be there. So it is called volume control mode. Pressure varies here. So what I mean to say here is in volume control mode, you have to monitor the pressure. In pressure control mode, what is happening here? Pressure control mode, you are controlling the pressure. You are controlling the pressure and time. You are controlling the pressure and time. So what varies here? Volume varies. Tidal volume varies and flow also varies. Flow also varies. So why I'm telling this one here, if you see the pressure time scalar, how it will be there, pressure goes up here, it will be constant for particular time, depending upon your time you have fixed here, like a 0.1, 0.2 second. So in pressure time scalar will be like this. Here what is happening? Volume varies. So in your ventilations, either you select volume control mode or pressure control mode. Or SIME again, we have to select either volume control or pressure control mode. Basically, SIME is a next version. Either you can select volume control or pressure control mode. Either you select volume control, you have to monitor the pressure here. Make sure pressure should not increase more than 30. Okay. What is the tidal you are keeping? You have to keep the tidal volume 6 ml per kg in ERDS patients. Have you managed with the 6 ml per kg when you already anticipated this patient in ERDS, or at least when you diagnose the ERDS, have you managed 6 ml per kg? That is, you have to answer. If it is 6 ml per kg, if you maintain plateau pressure around 28 or 30, then it's good enough. Imagine, if in spite of your managed 6 ml per kg, plateau pressure is more than 30 or 32 or 34, you can bring tidal volume to 5 ml per kg, even 4 ml per kg also. Okay, that is the main strategy in ERDS. In pressure control mode, you are controlling pressure. You are controlling pressure. So your pressure is fixed. Imagine pressure is 18 here. Here, what is varying? Volume is varying. So make sure tidal wall, when you have fixed the pressure is fixed. No need to monitor pressure. You have to monitor the volume. If volume increases more than 6 ml per kg, okay, imagine 6 ml means even 60 kg is 360 ml. If it is going more than 360 ml means you are causing volume trauma. You have to reduce the pressure 18 to make it 16. So this is how you should manage. Ventilator strategy is either you can select volume control or pressure control. Ultimately, you have to manage with 6 ml per kg tidal volume. Here, volume you are fixing, directly you are putting 6 ml per kg. In pressure control mode, make sure that you are delivering 6 ml per kg for each breath. That you have to monitor. So it is not the mode. None of the studies have shown that whether any mode is better than volume control mode is better than pressure control mode, or SIME better than volume control mode, nothing like that. There is no ideal mode at all. It is the intensivist who managing the ventilation that you should select whether proper, appropriate, measure strategy has applied or not. Another one is the PRVC. Everybody is fond of using pressure regulate volume control. That nothing but pressure regulate volume control means if you want to give 360, give 360 ml only. What it happens? It regulate the pressure. You can reduce the pressure or increase the pressure, or you can stabilize the pressure. It regulates the pressure either 18 or 16 or 14. so that you can deliver 360 ml tidal volume. That is called PRVC. That is the most famous PRVC mode earlier, but nobody now, everybody knows that mode is not at all the main strategy in ventilating ARDS. It is the how you manage, how you ventilate the patient is important. I think I've cleared the doubt about mode. So you have to make sure that PEEP selection, that is more important. I can discuss that also. And barotrauma, avoiding barotrauma, avoiding atrial trauma, avoiding volume trauma, those are things are important. So in this patient, another point here is, in this patient, this is the 6 ml per kg tidal volume to given. I'll try to erase this. Okay. Any doubt in this? Any doubt in this?
Sir.
It is clear. So first, initially, how to manage this patient. So this patient should be managed. Initially you would have been started 8 ml per kg tidal volume. Okay. I will take this slide only. That is better. So this patient here, can you see this? Here, 14 days of ATT given, started, patient on went for OT. Here, what is happening? I'm telling you. Here, patient was intubated, saturation was increased here. Why saturation, FiO2 requirement was increased, saturation started dropping and BP dropped. What do you feel? What is the cause for drop in BP and requiring more oxygen here? Sundar, what do you feel? What is the cause here? Can you see the slide? Hello?
Sir,
okay. Yeah,
sir,
I
able
can.
to see.
Yeah. So what is happening?
Sir, I think response will be a little bit difficult. Issue is there, sir. Past ventilation, is that the reason?
Okay, I will answer. Don't worry. Our network problem is there. So as you mentioned here, patient you are going to operate on paravertebral abscess here. Okay, this is the most important things. Okay, paravertebral abscess, and this is the this is a source of infection. When you surgeon want to operate any source of infection, it may be cellulitis, abscess, abdominal, appendicitis, cholecystitis. Once they touch it, it can cause bacteremia. So remember this, any patient if you operate, there is a high risk of bacteremia will be there. This bacteremia later causes septicemia. Okay. So it happens so sudden that there is a possibility of drop in BP as you mentioned here. Here BP has dropped here. Also what happened here, BP dropped and saturation requirement was gone up here. FiO2 was increased to 50 to 60%, 80%. So I wanted to know the ABG here. If you tell me the ABG, okay, we can diagnose exactly what is happening. Okay, imagine how to diagnose this. Requirement of FiO2, anytime. Requirement of FiO2 is gone up. Requirement of oxygen is gone up. So whenever oxygen requirement is gone up, you have to think of two causes. One is either lung parenchyma problem, that is oxygenation problem, pulmonary parenchyma problem, or it may be hypoventilation problem. Two things. Hypoventilation, if you take ABG here, if PCO2 is increased, that is a cause for the drop in saturation, but it will be very mild. It won't happen like this. But patient already intubated here, it should be a pulmonary problem. Okay, it should be a pulmonary problem. But whenever there is a low PaO2 is there, saturation is low, always think of two causes. One, either pulmonary, that is oxygenation problem, or carbon dioxide or ventilation problem. Ventilation means hypoventilation is the cause for hypoxia, or pulmonary problem with respect to lung. Okay. If sometimes when any bedridden patient, long-standing patient, okay, when you intubate, there is a sudden drop in saturation, sudden drop in BP. Also think of pulmonary embolism. Always important, because again ABG which may show increased PCO2 here because of the dead space, worsening dead space. This is another thing. Many people, we don't know the dead space. We see, we learn theory and all. Practically, when come, we will forget this. Dead space is the again important thing. Okay, we can take another class only for this. Okay, always think of dead space, that is pulmonary embolism. So whenever there is a drop in saturation suddenly and BP drops suddenly, think of one is usually pulmonary problem will be there, or pulmonary embolism. Also think of hypoventilation. You have to take ABG here. And you have started Nordinal here. So what ideally I will say here, you would have been given a lot of fluids here. Look at the IVC, and IVC if is low, fluids, and along with Nordinal. That you are given already. Blood loss is not much here. Okay, you are given crystalloids were balanced to attain urine output more than 30. So 30 ml per hour, you want to maintain 0.5 ml per kg per hour. That's also good actually. So this is okay. Here, what is happening here? You thought of perioperative acidosis and all. Here, I want to tell important here. Effort requirement maintained decreased here. So you have ventilated the volume control, and this is what I want to highlight here. First post-operative day, when already you told that bicarb was low. Bicarb was low before. I think it was, how much it was, bicarb? Bicarb was low here, and this patient are requiring vasopressor. In that case, shifting directly to the volume control to pressure control, CPAP mode is not very good ideal choice here. This is because weaning starts when the underlying pathology resolves or resolving. This is a very important point. You have weaned very early here. As you think post-operation, you have weaned it. But see, have you assessed why the patient is requiring FiO2, why the saturation was low, why there is a Norden requirement is there? That is the key here. If you have taken X-ray here, you might have been know why there is X-ray, any patches is there, patient already in early RDS, or you have done 2D echo showing any RVR dilatation to know that pulmonary embolism is there, lower venous Doppler. Okay, I think you need investigation here why there was a first of all requirement of high FiO2 and noradrenaline before weaning. Try to correct that problem, then only you have to wean. This is a very important here. Here, I think it is early weaning is not a very good option here. And when the patient is noradrenaline is still requiring is that, don't try to wean, put on full support, make sure noradrenaline weaned off, identify the cause for drop in BP, then treat, and then wean it. Glycemic status you told requiring DNS, requiring 70-80, that again indicates hypoglycemia is a sign of sepsis. See, sign of sepsis, not only you see high total count, that is a lot late signs, okay? Sign of sepsis also there is a increased rate, it is a sign of sepsis, or decreased PaCO2, it is a sign of sepsis. If CO2 is low, like a 20, 30, 20, 24, that is also sign of sepsis. It is a decreased PaCO2 or hypoglycemia. When hypoglycemia is there, again you have to think of there is sepsis going on. This is a classical case of sepsis, and you are telling that pH is 7.2. Always know, I will mention, Sundaram always mentions 7.20 or 7.29. You have to 2 digits should say. See, 7.20 is very low. 7.29 relatively okay. You have to tell that 3 digits, means 2 digits, 2 decimals actually. Don't tell only 7.2. If 7.20 is very bad, 7.29 still patient is improving. So always in pH, you have to tell 2 decimals. Here I can say 7.20 or 7.24. Still it's very low. Should not extubate here or extubate here when bicarb is 12. As I told, bicarb 12 means there is a cause for the acidosis. It may be lactic acidosis, as you mentioned, lactate was high. It is a classical source of sepsis. If the diabetes, look for the ketone bodies also. So PCO2 is normal limits. You are telling again PCO2 is normal. That is again not a very good sign. PCO2 normal means bicarb 12 means if you apply winter formula for the bicarb, 1.5 times the bicarb means 12 plus 6, 16, 18 plus 8. 24 should be PCO2 ideally for this bicarb of 12. If PCO2 normal means you are hyperventilating these patients. You have been increased the rate. As I mentioned here, all sepsis patients require high respiratory rate. How to calculate high respiratory? I told you, calculate minute ventilation, how much the patient want. Usually 100 to 200 more than the usual basal level, usually 20 to 14 liters, divided by the tidal volume. That amount of rate is required here. So you are managing rate was low, hyperventilation. That is not good actually. So CO2 low also causes respiratory acidosis, as well there is metabolic. Actually, there is mixed respiratory metabolic acidosis. LFT is worsened, yes, and hypotension is the hypoperfusion to the liver and kidney can cause worsening. When there is a risk of organ failure is there because of hypoperfusion, wait for weaning. We should not wean this patient. Put on full support here. That is again. And tachycardia was above 120. Again, telling you again and again, tell that patient is not fit for weaning. Wait and try to treat the and put appropriate antibiotic also that I didn't mention. That is also very important. So ventilation here is you would have been not weaned early. That is very important. Full support, protective lung ventilation, 6 ml per kg, high rate with the metabolic ventilation demand. PEEP maybe require 8 or 10 depending upon the lower infection point if you are able to get 3C, and try to maintain this ventilation for 2 to 3 days. Make sure that organs are okay, kidney, liver is okay, tachycardia is settling down, then we can wean. Here what is happening, we'll see. Here patient sedation stopped and analgesia continued. Okay, sedation, you are talking about sedation, how to give sedation, ventilation and all, relaxant and all. See, when the patient on ventilator, mechanic ventilation, usually first 24 to 48 hours, you need relaxant. After that, usually you don't need relaxant. You can stop. Okay. So mechanic ventilation, sedation, even in ARDS also 24 to 48 hours. After that, you don't require continuous relaxant. Even we stop early, 24 hours, then go for intermittent relaxant for first 48 hours, then stop relaxant. That is the best way. Why? The more you want to use muscle relaxant, what happens? There is a problem with the muscular problem, neuromuscular dysfunction problem happens if you use along with some drugs which can worsen the neuromuscular dysfunction that can prolong weaning. Patient can not able to trigger and requiring longer duration ventilation, and patient get infection post-op and die because of the infection. So relaxant, try to avoid 24 to 48 hours. Even studies tell that cis-atracurium, if you use for first 24 to 48 hours, there is a mortality outcome benefit is there. For 48 hours, you can use. Sometimes you can use intermittent dose of 72 hours, then you can stop it. Okay, usually not required. And the moment I'll say ARDS, you should know the definition of ARDS, new definitions. If the moment of ARDS, it won't resolve 1 or 2 days. It takes weeks to get 1 week, 10 days, 14 days. So you need time for ARDS to recovery. So till then, you can manage intermittent relaxant, first few days. Then you can go for only sedation. And you can stop sedation early also. Okay, ventilated parameter, tidal volume, oxygen saturation were within normal limits in first overall. So we extubated, but if you see before extubation, you see bicarb still is 15 bicarb, and you also mentioned it is a 7.30 or 7.35. 7.35 is normal, 7.30 still low. So you always maintain, see that 2 decimals. Bicarb is 15 here. So still I feel not to wean now. Extubation may be hurried here. And the second post-op, what happened here, shifted to ICU here, worsening this function, kidney and liver. Usually 1 or 2 days, it won't improve actually. It takes time with the kidney and liver. So you have to wait for liver to improve. Even though it is ATT, you should wait. Tachycardia seems to increase. Here patient improved and again worsened. Again, you have to think again, is there sepsis is worsening here? Second day only sepsis worsening possibility is there. Maybe is responding for your fluids and all respond well, then worsening. or any other problems can see, or even surgery, still source control is not adequate, still septicemia is going on, bacteremia is going on, that you have to see source control. So you have to, in second post-op day, sepsis worsening means still there is a, I feel still we need the sepsis, what we seen in first day itself is there, still we have to wait here. Not low dose of noradrenaline, nothing called low dose and high dose, okay. 65 65, very good, it is the right goal actually. You have to maintain fluid therapy. Look at the fluid therapy according to IVC, RARV, we can maintain fluid therapy. Sudden bradycardia, see, sudden bradycardia that happened because of the patient still not improved and it's extubated, actually requiring still ventilation. Okay, what happens here? The patient is tachypnic in sepsis. What happens? Usually normal lung, normal healthy lung, usually 3 to 5% of the oxygen is required for the lungs, lung muscles, respiratory muscle for work of breathing, 3 to 5%. But in sepsis, rate goes significantly high, so that it may go up to 50 to 60, 70% of oxygen is going to the respiratory muscles only. Whatever you are giving oxygen, 50 to 60 or 70% going to respiratory muscle, then what happens to the heart? Heart may not get enough oxygen. Kidney may not get enough oxygen. Brain may not get enough oxygen, then may go for cardiac arrest. This you have to remember. Ventilation, not only for the lung point of view, to reduce the work of breathing also, you need mechanic ventilation. Again, I feel would have been continued ventilation to reduce the work of breathing, to reduce the oxygen demand from 50% to 5% directly, so that more and more oxygen given to the heart. So that's why patient has a bradycardia, resuscitated. And post of what happened here? Post of patient went for difficulty ventilation. This is the very thing important. I want to know here what is the ABZ and all. This is the ARDS ventilation. I think patient gone for ARDS here. We can discuss thoroughly how to manage ARDS mechanical ventilation because of the time duration actually. So here patient had extreme tachycardia, tachypnea. So again, continuous tachycardia, I always want to rule out pulmonary embolism because long standing 2D echo along with the sepsis, post cardiac itself have a severe tachycardia and tachypnea, but still you should rule out this one. And acute liver dysfunction definitely worsen because of hypoperfusion. Noradrenaline requirement also increase because of the hypoperfusion worsening sepsis, and mods like patient will succumb to that. So I think I've answered your question. Ideal mode, then nothing called ideal mode here. So ideal way is important. There is nothing called ideal mode, ideal way. How you want to ventilate this patient. Ideal way is important in ARDS. ARDS, I will discuss again once again. Low tedium was the key here. It's the key. Newer modes not required. Newer absolutely not required. Even though you use newer modes, again ideal way, low tidal volume, plateau pressure less than 30. That was again same. Principles are same. Either use the car or electric car. I told Mahadev told very nicely, either use electric car or regular car, or if you use a train. So what is known? Principles are the same. Sedation in this setting can't worsen liver function. Sedation in this setting, can it worsen liver function? So sedation, I'm telling you, sedation you have to optimize. If the patient is going for kidney failure, reduce the sedation, fentanyl, midazolam. If you don't sedate, it will accumulate. It causes longer duration of ventilation and difficult to wean. So sedation, I will tell you, ideal way, need basis. First 2-3 days, yes, need, then go for need basis. Paralysis, I told already, CME is still better. CPAP is CME, when the patient is completely okay, tachycardia settling down, tachypnea settling down, X-ray is okay, ARD settling down, sepsis is okay, then only you can go for CPAP pressure support. Persist tachycardia, how to, see that one thing I forgot to mention here, heart protective ventilation. That I will discuss in another class. Heart protective lung ventilations, heart protective ventilations. So lung protective ventilation in ARDS also we will discuss, and heart protective ventilation also we'll discuss in another class. I think this is the anything. I think Mahadev was Mahadev. Anything you want to add?
You've covered all the questions and whatever Dr. Sundaram has asked. So I think whatever you said is, there is nothing much to discuss on that. So if there is any doubts, we can clear it together.
Nesra, any doubt is there? Nesra, is exam going?
Yes, sir. Sir, there was a hypotension and already PEEP was there. To bring the FiO2 down or to PO2 high, was PEEP required? Was there any change in PEEP required,
I think Madhav
considering the
will.
hemodynamic instability?
Got it, got it. Madhav? Madhav? Okay. Okay. Nesra, can you able to see my slide here? Hello?
Yes, sir.
Can you able to see? See, PEEP I'm telling you, okay? So imagine PEEP is, you want PEEP of 10. How to select PEEP 10? We already discussed that for you. Okay, this imagine PEEP you want to 10 or imagine PEEP 14 only, slightly higher side. Okay, the moment you keep PEEP 14, what happens? You are giving positive pressure ventilations. Positive pressure ventilations. So what will happen? Positive pressure ventilation reduce the venous return. Venous return reduces, and also it reduces the venous return. It reduces, also reduces the right ventricular, input and right water output. Then later it reduces the left ventricular output. Basically, it causes hypotension. So PEEP can increase the positive pressure ventilation and reduce the venous return and cause hypotension. Okay, PEEP causing hypotension should be managed with the fluids. So should be managed. You have to give more fluids. The moment PEEP you give, BP drops means patient require more fluids. That is called, it is a fluid responsive status. It's the ideal way. The moment you give PEEP, more PEEP, BP drop, give more and more fluids. Don't try to reduce the PEEP. So fluid responsive is easily identified by increasing PEEP, making sure whether the patient is going for a drop in BP or not. So it is a fluid responsive patient, give more fluids, so we can continue PEEP 14 or 16, whichever the optimal for the patient, then give fluids and try to correct the fluid responsiveness. I think I've answered.
Okay, sir. Yeah, yes, sir. Yes, sir. First focus we have to give for FiO2, PEEP,
Yes.
and then later BP can be managed with fluids and
Madhav,
vasopressors.
Madhav,
Okay,
I
sir.
think it was not audible.
Yeah.
Nesara was asking this question. And one more question is there from Richard. When is the right time for surgery in this case? Should we delay the surgery? Madhav,
No, if the patient is going into sepsis, I think we have to take her up. So your patient is already tachypneic, deteriorate, so that they will not get the time to operate onto her. We have to optimize and simultaneously take the source out, otherwise patient may deteriorate further. So it's an emergency. If there is an abscess, we'll have to drain it out. The patient has a tachycardia, tachypnea. We didn't have the preoperative but if we had done, it would show some metabolic acidosis, like it's going up. So this is time that we have to take the patient up for surgery.
Okay. I think Richard, you got this one, no? So whenever sepsis is there, you have to go for source control early. There is no need to delay. So optimize the patient means stabilize the patient and go for surgery. Any other questions? If there is no questions, we'll end it. Good. Actually, Sundaram, there he was stuck in OT, it seems. So there was a difficulty in the, in the interaction. Okay, thank you. I think one more
Thank
question.
you.
Who can, okay. Oh, nothing, no more chat. Okay, thank you, Mahadev, and thank you all. So next case also, if anybody come with the case, we can discuss and see that patient, how to manage the patient. So that will be a practical problem. It will be easy for you. Thank you. Thank you, one and all. Thank you.
Thank you, sir.